I'm Margaret Dempsey from Barwon Medicare Local in Geelong, and this is Jill Mann from the Respecting Patient Choices program at Barwon Health, which is based at the Geelong Hospital. So just so that you know, in true collaborative style, which is what our project is about, we're actually going to co-present. We've got a big love fest going on between us, so we'll present together in a nice professional way. So when I'm speaking, it's just so that you know, it's about from a Barwon Medicare or from a Medicare local perspective, engaging with general practice. And when Jill's speaking, it'll be from that Barwon Health Respecting Patient Choices program point of view. So we are here to talk to you today about working with general practice to raise the understanding of advanced care planning. My background is as a nurse. I've for 30-something years, working in the emergency department for quite a length of time. Then I moved to general practice, so I was working as a nurse in general practice. Then I moved to the division of general practice, which was called the GP Association of Geelong then. Divisions were, I'm not sure how many of you know and understand that concept, but divisions were around to support general practice, GPs, practice nurses, which is my passion. We have then since moved to be tranche one, transition to a Medicare local, which was a fairly smooth transition for us because it was really the GP Association of Geelong transitioning to Barwon Medicare local. We took on a bit of extra patch around the Colac, Apollo Bay region, but the rest of it was pretty much the same and sort of business as usual. But we have grown and we're still in a process of growing and transitioning to support other primary care. So in the past it had just really been general practice focused. Now we are looking to expand other primary care, allied health, aged services. And it is something that's a process, it just doesn't happen overnight, so we're working through that as well. I'll let Jill introduce herself.
Thank you. My name's Jill Mann, I'm from Barwon Health. I coordinate the Respecting Patient Choices program for Barwon Health. My background is I'm a registered nurse Division 1 with I won't tell you how many years experience in ICU, but a few. And also in that ICU time, a bit of research and organ donation liaison nurse, that sort of thing. I've been employed in Respecting Patient Choices program since July 2005, initially as a project officer, 3 days a week, just me, to implement advanced care planning across Barwon Health. And we've expanded somewhat now, and we are an ongoing program. I'm the coordinator of that program. And we provide advanced care planning across all sectors of Barwon Health, but also to the extended and wider community. And we are a bit blessed in Geelong because basically working for the major health service, most of our catchment are going to be our patients at some time, so it makes it a bit easier. We also obviously provide lots of community awareness through presentations and also training of health professionals to facilitate advanced care planning. So it's sort of turned into a fairly big role now. And our program now includes an outreach service, which we'll be talking a bit about with this presentation today.
Oh, you're doing that. Good.
So just so that we're on the same playing field, this is a definition of advanced care planning, and this is taken from the National Framework of Advanced Care Directive. So it is an advanced care planning is a process for planning for future health and personal care, whereby the person's values, beliefs and preferences are made known so they can guide decision making for a future time when the person's unable to make or communicate their own decisions. Advanced care planning often will result in an advanced care plan or directive of some sort, and that's what we help promote as well through our service.
So we do hope that by the end of this session that you'll be able to identify reasons why general practice is ideally suited to initiating those advanced care plan discussions, and realising that there's already an established rapport between the patient and their GP. And when I say and their GP and the practice nurse and the practice team and the reception staff, patients walk in and the reception staff will quite often ask them how their family is, how their little dog Fluffy is, because they know. So it's general practice is very much an area where there is that established rapport between the health professionals and the patient, and decisions can occur in the absence of acute crisis. So if patients are actually admitted into the hospital sector, someone comes along to start that conversation about advanced care planning, I think Jill will tell you, the data shows that's not always the best place to be. So the other thing is we hope that you can explain or understand the worth of the advanced care planning process for patients and for health professionals, how it benefits the health professionals, and also how it benefits the community. So building partnerships and a team approach to advanced care planning, which is what we're really speaking at mostly today.
So this is just a little snapshot of advanced care planning activity.
Thank you. What I guess probably starting at the very start, the main take-home message that I want to let you know is the projects that we've done in Geelong and what we've done have been achieved little bits at a time, little processes, talking to people, working together along the way. It's not something that I'm telling you all about how we did it and you'll go up and implement it overnight in your areas or settings, because it is something that takes time to implement. And we've been fortunate that in our Geelong region, there's been a few different groups and different reasons why things have been able to happen. Just sort of briefly through, we have the Medicare local, to stop doing that. We have a palliative care special interest group of GPs who they meet once a month for a breakfast meeting. Group of GPs interested in palliative care. They also meet with the palliative care specialists from the Geelong region, the community nurses that visit, and there's usually guest speakers each month and different people. So it's probably a group of about 24 people that meet monthly. And that group has actually been going for 15 years. So well established. So what I'm saying, it doesn't happen overnight. This group, although advanced care planning isn't just related to palliative care, there's obvious links. But this group of GPs are a fabulous group that I use as a sounding board. And quite often when I'm attending the meeting, I might actually ask them other questions that are not palliative care related, but I just want to get a general mix of GP ideas and input. So we use that group very well. And very fortunate to have this dedicated group of GPs. We also run an annual forum at our Medicare local. It's usually in October. It's a dinner event, guest speakers, case study presentation by the GP, and it's actually facilitated by that special interest group. We sit around in those meetings, we discuss what topic we're going to discuss for the forum. We have one of the GPs will be the case presenter, so they'll say, I've got a good case for whatever the topic is. We have a panel of experts and it goes from there with lots of interactive discussion. And those forums have probably been going, I think, probably about 12 or 13 years. And quite well, everyone knows the Palliative Care Forum, and they all get an invitation and want to come, and it's open to GPs all around our region. The Medicare local in the past, 2008 to 2011, was actually the GP Association then. We got some funding through Doha to be involved in a rural palliative care project, and without going into all the details of what that was, we had the University of Wollongong evaluate our project for us regarding palliative care services in our area. And one of those recommendations was that they highlighted the value of advanced care planning, and their recommendation was to progress and pursue advanced care planning. So it's another reason that, that it took our interest and we sort of built on it from there. I will explain further, but through one of the annual forums, the discussion did come up about advanced care planning opportunities in general practice, and there was a pilot project completed in 2010 that Jill will speak more about, but it was between Barwon Health and the Medicare local working together. That then led on to the Advanced Care Planning in General Practice Outreach Facilitator project, which has been going from 2011 to 12. And we were also able to get funding through the Australian Primary Care Collaborative Wave to select a topic of need in our area, and we chose advanced care planning and built that in through another project. So through opportunities, funding opportunities, and other passionate people in our area, we've been able to build and drive, but it certainly hasn't all been me or just Jill. It's been a truly collaborative effort. And when I say that, as I said before, things don't happen overnight. So it really is a case of eating the elephant one small bite at a time. So thinking about what you're wanting to achieve, setting small goals that are achievable. Because if you walk in the door with your knife and fork and that's what's facing you, it's an enormous task. So if you actually just try to, break off bite-sized chunks, I'm probably, preaching to the converted, you know that anyway, but just trying to set small goals, and that's what we found has happened throughout our collaborative efforts together. Little things have happened that have then gone on to be something else and be something else, and now we've got some really good results from that. So just remember eating the elephant, one bite at a time.
And being an absolute opportunist.
Indeed.
Which I am.
And apologies to the vegetarians in the room.
So this is really how it all started with the GP Palliative Care Forum that Margaret was talking about, that special interest group of GPs in palliative care. I've been fortunate to have been asked just about every forum since I started in this position to talk about advanced care planning and where we were up to. So, at the 2009 forum, after our presentation, we'd been going for a few years by then, one of the GPs came up to me and said, look, I think we need to clone you and have a few of you coming out to general practice to do this job at that level. And that was over a glass of red wine at the end of the evening. But it was a pretty exciting thought. And so with the CEO of the now Barwon Medicare Local and Marg, we had a couple of meetings and we hatched this plan, and we instigated a quality improvement project in 2010, which was a 6-month pilot to see how we could run advanced care planning clinics in general practice. And so that was with 2 general practices in the same area, the same locality. So we aimed to get 100 advanced care plans. We ended up with having 96 patients referred in that 6-month period, with 82 of them going on to complete advanced care planning documents. So that's not just like a statutory document, not just a power of attorney, but also about their wishes and some refusal of treatment certificates. So that was an extremely high uptake rate for advanced care planning. On average, through our program, the uptake rate was around 48–50% once we had referrals. So this was a huge completion rate of about 87%. So quite frankly, if your GP says, look, I think this is a really good idea, you need to think about it, and they referred, people tended to go on and complete advanced care plans. So a message there is if your doctor says do it or your lawyer says do it, you tend to do it. We also get referrals through lawyers now as well. So with those really good, that really good outcome of that initiative, the champion GP, Dr. Milner, who first approached me in 2009, then had a conversation after that initial pilot project with our CEO of Barwon Health, and he rang me very excitedly one night at home and said, guess what, I think we've got funding to do it on a bigger scale. And I said, I had that happen. He said, oh, socially we were at the same function, and again over a glass of red these conversations happened. And I said, Rick, are you sure? Like, I was very excited but a little bit sceptical. So, but no, he was correct, and after a few planning meetings, we then ended up with this 2012 project, 12-month period, where we engaged with 18 general practices in our region. And so that was from the Geelong area down to the Barwon Peninsula, down to the Surf Coast and out to Lara. So it's a fairly widespread area. And we were funded by our CEO to provide 2 EFT to train up advanced care planning outreach facilitators. And so we had 4 staff fill those positions, and they were allocated to general practice on a given day when a room was available. So it was a bit of a scheduling nightmare, but nonetheless we did it. So with very good outcomes from that, we didn't quite reach our aim, which the CEO thought was a good number, and again I was a bit sceptical about, but nonetheless we ended up with about 1,400 referrals and 1,200 completed documents through that actual project. The actual program did reach over 2,000 referrals for the year 2012. So this year we've been able to continue with that funding, and we now have an outreach program for advanced care planning, which really the scope of currently is in general practice, but I can imagine that we'll build and go much wider than that. So with our outreach project, this was our initial aims, really to engage with general practitioners. I'd have to say back in about 2007, 2008, we had like 4 to 13 referrals from GPs, and I'll show you a graph that looks fairly exciting how that's increased. But we knew that it wasn't fully embraced by GPs yet, so this big project really helped with that. And by providing a resource, i.e. human resource in the form of a trained facilitator, certainly helps. The aim was to provide facilitation to 2,000 general practice patients. However, we got about, I think it was 1,380. And then to demonstrate that this model can be sustained, but obviously with the right resources. And this was all based on that little project that was concocted one night at the Palliative Care Forum.
The other take-home message is red wine is a good thing.
Red wine, yeah. Especially if it's provided by the Medicare local. So this graph just demonstrates some of the activity that occurred over the 12 months of our GP outreach project. These are the de-identified practices, and you can see that the referrals were quite high. There were some sort of lower functioning practices, and I'm not really sure why they never really got on board. But I have to say, if the practice approached it as a team event sort of thing, and that was agendaed on all their meetings, if it was part of their routine processes, it was certainly implemented much better. We've also, after the 2010 project, I should say that we included it, Margaret was instrumental in this, included on the over 75 health assessment template, so it gets broached that point as well. So I just would like to point out that Practice A is a sole GP. So his name's Frank, and we think Frank is just really frank with his patients, and he does very well. So he does an amazing job, and there's a really high uptake, as you can see.
Perhaps the fact that his practice is located right next door to a funeral parlour might scare the bejesus out of some of his patients. I'm not quite sure.
And on that comment, I'm glad I've got a graph later on that shows increase in uptake of advanced care plan doesn't mean increase in death rate, so it's okay. So I don't think the funeral parlour got anything out of it. Okay. So this really just demonstrates how our referrals have changed over time, and if you look back in 2006, 2007 when we first started collecting data on our activity, the blue is fairly not even noticeable. In fact, we had a lot of GPs at that stage who were very wary of what we were up to, and indeed were quite reticent to even sign off or witness medical power of attorney documents. And then you look at 2012 and they've certainly, it's sort of blown off the scale somewhat. So it's really pleasing to see how with some focused effort, it's really made a big change.
Okay, just keep that. I guess if you see that when we started focusing our effort was 2010, so you can see the rise of the GP referrals from 2010.
And it was sustained in 2011, which was really good. Yeah.
Without any particular funding or project or anything, you know, the 2010 project was 6 months, that was it. And then in 2011 we were doing lots of talking and discussing, but as Jill said, the actual level of GP referrals was sustained. And then of course in 2012 with the Outreach Facilitator project, lots of energy into it, and you can see the results, which is the most outstanding graph I've seen, I think.
I might just flash back, sorry, but if you look at the very, your right-hand side, the other, they were practices that would actually engage in the project. So we still had really good referrals from other GPs where they would send their patients in to see us at we've got a consulting room we can see people. So they weren't included in the project, but we still had good referral rates for other GPs. So word of mouth, you know, if they're doing it, we better do something too. Now, how does this impact on our health service? Because I do work for our health service, and here I am spreading our resources out into the community. So TGH is the Geelong Hospital, and McCullough Centre is our subacute site. So we had, from just that project cohort, 297 episodes of admissions to acute health. So the advanced care plans are useful. And the outcomes of those episodes were 27 were actually discharged to our subacute site, and of those 17 went home, 9 went to aged care, and 2 have subsequently died, and 1 died in McCullough Centre. From the admissions to TGH, our acute site, 236 went home, 16 to aged care, 9 were transferred to other hospitals, 7 were deceased. Our palliative care unit sits in our subacute site, so direct admission to palliative care unit and that person deceased. So these are all people with advanced care plans that have accessed our service just from this cohort of people. And this is our activity, just a little table to show what happened over the 12 months. I think it's actually 1375 referrals, overall program over 2,000, completed plans there, declined and deceased. So decline rate isn't huge with the GP cohort. This is the graph I was alluding to earlier. This is our program activity over time. And as you can see, the pink line is deaths with ACP, and thankfully that just because there's an increase in activity and people actually go on to do their advanced care plans doesn't mean that they're imminently going to die. And that's sort of, I guess, one of our cultural things is if we talk about it, we might make it happen. So hopefully this shows that it doesn't. The black line is contacts. Now that's way off the scale because we do collect data on all our contacts, and that includes our review process with our program. Anyone that's done an advanced care plan has an annual review through it via a letter, asking if there's been any change in their health or circumstances and would they like to contact us back if they require any change. So that's included in the contacts, so it sort of makes it look pretty over the scale. So yeah, our reviews this year will be enormous, no doubt. But it just closes the loop, I think, for advanced care planning. Look, we had lots of case studies that we could pick from, but this is just one of them that came to mind. It was a lady that was admitted with an advanced care plan which she'd completed through the general practice clinic. She completed it in April 2012. She was pretty well, had a bit of hypertension, was very active, 84-year-old. And actually, in her discussion record with the facilitator, she states that this lady actually had a bit of difficulty discussing her wishes and hadn't put a whole lot of thought into it pre the appointment and couldn't imagine a time where she might need an advanced care plan at 84. So the ACP content was that she wanted all treatments while there was a good recovery to independence. Her independence and her active abilities were really important to her and to self-care. So in August in 2012, she was admitted with an altered conscious state. She was initially intubated for low GCS and ended up going for a brain CT, which showed infarction. The advanced care plan was clearly acknowledged in emergency department, and in accordance with her wishes and discussion with family, she was extubated and palliated. So just a very quick example of how it can work in the ED even. From a very well lady who hadn't even thought about how she might come to her end. We audit all our deaths with advanced care plans in Barwon Health, and these are just some sort of notes, an example of what we're starting to see quite commonly in discharge summaries, on limitation medical treatment orders and medical plans and that sort of thing. These sort of comments that not for lifelong treatment due to nature of disease, as per the advanced care plan and patient's previously documented wishes. So they're actually acknowledging them. Comfort care was in keeping with his wishes and per his advanced care plan. Family reported the patient had clearly expressed that in such a position did not want any heroics. And that person also had an advanced care plan to guide them at that time.
So it also helps that the patient has had that discussion with family. So it's not just necessarily what's written in the document. Family can support that and they know and they agree, and that's a much easier time for the family. A lot of patients say, actually I think it's going to be the next thing here, they don't want to be a burden to their family, they don't want to give the family that decision to make when often it's a time of crisis and difficult. So that's what gives the patient comfort, that they're actually relieving that burden on family.
Yeah, and I guess an observation is that, as Marg said, that in all our audits, it's quite obvious there's been discussion. It's not just the documents, but the previous discussion had 4 months prior is very helpful in organising family for that time. So yeah, these are patient testimonies. We do satisfaction surveys for all our patients that complete advanced care plans, and so these are the things that they tell us is why they've gone through the whole process. So very strongly, these are the themes. Of course, we haven't documented all of them. A big one is I don't want anyone making my decisions for me. I don't want to be a burden, and it gives peace of mind. Some people just think it's a very practical, sensible thing to do. Hand up to Marg.
So I guess the other message is having discussions, conversations and working as a team. So within your own health facility area, with other agencies, within the community, with patients, it's all about that teamwork. And as the slide shows, they think they're on a good thing. One's going to start at each end and they're going to meet in the middle, but it all goes haywire because they haven't really had conversations way back at the very start to set a plan on track. So 2 things to recall. Eating the elephant one bite at a time, so little small chunks to make it manageable to work through your processes, and engaging others and really working as a team. Thank you. So I just want to make it clear what sort of happened with our project. Barwon Health run the Advanced Care Planning program. They were looking to build their project within general practices. They recruited 18 general practices. So at the time they were doing that, Dr. Rick Milner, who we've said is a GP at Lara, at the Youngs Medical Centre in Lara, great advocate, great champion. He was knocking on doors and ringing up GP mates in other practices on his time off and putting in a whole lot more work than probably he should, but was a great champion to our cause. So through Jill's project, there were 18 general practices with varying number of GPs involved that had actually put their hand up and said, yes, we want to be involved in this advanced care planning in general practice project. We'll make time available, we'll make room available, the outreach facilitators can come in, we'll have the discussions with patients and lead on for them to see the outreach facilitator. So that process had actually already been in place and started at a time when Barwon Medicare Local was able to get some funding through the Australian Primary Care Collaboratives. I'm not sure if any of you are familiar with that Collaboratives project. It's about quality assurance and building capacity within the work that you do and thinking about why you're doing it and reviewing what you're doing. So through that project, as I said, Barwon Medicare Local was able to get some funding to support general practice. So we actually, the national wave was we could actually choose a need or a gap in our area, and we selected advanced care planning because we knew there was already some work being done, and through this project was a way that we could further help to support GPs and general practice. So there was actually funding provided in incentives for the practices. But what I liked about it is the practices had already signed up. They'd already put their hand up when there was no financial carrot dangling in front of them. So they did it for the right reason, in knowing that it's a good thing and they really wanted to be involved. So that was great for us because we sort of walked in and saying, well, if you want to be a part of this project as well, here, I've got a wallet. I can, give you some funding to support that.
So they like Marg a lot more than they like me, obviously.
As I said, I loved it because it was easy because I was engaging with practice teams, GPs, nurses that were already engaged and on board, as I said, when there was no financial incentive in front of them. So it certainly made my collaboratives project easy. So through that, it was just opportunistic. As I said, it just sort of came along at the right time and we could do it. And there's lots of, paperwork and other things behind the scenes, but that's basically the gist of the project. So we held some quality improvement workshops in June and November, which were for the GPs. We actually had, of the 18 practices that had signed up for Jill, 17 of them came on board with ours. And I'm not quite sure why the 18th one didn't, because they were still doing all the work and everything. It just sort of didn't really get the dollars along the way. Maybe they thought it was too good to be true, there's potential in that. So we actually had 17 practices that were involved in the collaboratives project. We ran some workshops where we had a GP and one other from the practice. So it could have been the practice manager, it could have been the practice nurse, it could have been another GP. It was so 2 people from each practice that were involved in the ongoing advanced care planning project. What we found just prior to the first workshop in June, Jill identified that out of all those practices, A to whatever, There was 4 of them that were performing quite well in their results, and you know, Frank at Practice A was one of them. There was 3 others which ranged from the solo GP with no practice nurse, his wife's the practice manager, you know, it's all a very small clinic, and he said it works because he's got that control of what he says and does, and it's there. Other practices had much larger practices, lots of GPs, practice nurses, and I think what worked for those practices was, as Jill had said earlier, that team approach. They had monthly meetings where the advanced care planning was on the agenda item, so they brought that up at every meeting they had in the practice. The reception staff were on board. They don't necessarily need to know all the ins and outs of advanced care planning, but they knew enough to have comfortable conversations with patients if they were sort of asked something, if they said something at the desk. The reception staff knew what it was they were talking about, could direct them, you know, come and have a chat with our practice nurse or speak to your doctor about that. They could give a reasonable answer, as I said, without necessarily knowing lots about the intricacies of advanced care planning. So we identified four high-performing GPs in clinics, and at the workshop we actually did the little sort of round tabletop discussions where those 4 GPs actually then represented their cases. So they said what size practice they were at, how they were doing it in their practice. Many of them utilised the over 75 health assessment, and lots of practice nurses go out to patients' homes. And the whole point of the over 75 health assessment, all these people are 75 years or more, regardless of how fit and well or frail they are. So in that health assessment, nurses are talking to patients about what will happen if you're no longer able to drive, or you know this, and your spouse is not there. What will happen, and getting patients to think about how their life might change. So advanced care planning is such a perfect time for the nurse just to plant the seed, a couple of minutes. Talk about advanced care planning. Do you know what that is? Many have said no. The practice nurses in Geelong take out a little flyer from the Respecting Patient Choices program, hand them over a flyer, talk to them very, very briefly, but give them that and say, you know, have a read of this, and then when they get back to the practice, they can talk to the GP. A lot of GPs have said to me, I've never sort of initiated, you know, end-of-life discussions with patients as such, like when they're fit and well, and I'm worried that if I start now, they'll think, oh, he's not telling me the results of those blood tests, he's not a bit sure, and the GP feels uncertain about broaching the subject. I think your studies have shown that actually a lot of people, if the GP says, you know, it starts initiating that conversation, the patient's shoulders drop and go, oh, I'd love to talk to you about that. Well, yes, you know, they're actually looking for the health professional to start that conversation. You know, they're not sure how to do it themselves, or they're thinking about it and not sure how to broach it with family members. So to normalise it in conversation, and for the GPs, once the patient comes back after having the health assessment, it's there on the form. The GP can quite easily say, I see the nurse has spoken to you about advanced care planning. Did you understand what that meant? How did you feel about that? And it starts a normal process so that when Mavis is up at the Bowls Club and she's talking to Myrtle and they're talking about their health assessments, because they do, if they're talking advanced care planning, it's all normal because everyone's been asked the same question in the same way, and it's got no correlation with how well they are or not. So we did have those 4 GPs presenting their information to the others in the area, and our evaluations after that showed that that was really powerful to act. Jill and I, this is sort of our job and what we do, and yes, we'll spruik it till the cows come home, but people actually want to know how it works in their practice, and what better way to actually hear from other GPs in the area that are, you know, just normal people doing their job, how it works for them, how they can build it in. Because we all know time is a massive issue in general practice and in other settings as well, so trying to build some sustainability into that. We had, with those workshops, Dr. Rick Milner he chaired the workshops, and as I said, we utilised the GPs that were already there to speak to others and to gain some learnings from that. We invited the outreach facilitators so they could hear what the GPs, they actually had some great advice to give the GPs. What we found is a lot of patients, those who'd actually been well prepared by the time they saw the outreach facilitator, things worked much easier or much better. So when a GP or the nurse had a bit more time and discussed the concept and the patients were well prepared, by the time they spoke to the outreach facilitator, the process of implementing their advanced care plan was much easier than saying, go and see Jill over here and she'll help you with your advanced care plan, and, you know, sort of for some, and maybe that was the practices that didn't perform particularly well. Maybe there wasn't that level of preparation to discuss with the patients.
The other thing that we encouraged was that GPs did their own advanced care plan, and we did have a number go on to do that as well, so that helped them understand how the process worked and the sort of things that we were expecting their patients to go through. So that was fairly powerful as well.
They did enjoy that. We also ran an advanced care planning update for practice nurses, which was a separate thing, but to gauge their idea. And as I said, really, although advanced care planning is for everyone and not just if you're over 75, when you're working in general practice, you're really bound by claimable item numbers to make it a business model. It's Medicare, it's how it is, so we really can't fight that. So to look for ways that are actually already within the general practice setting and where there's item numbers that support that is sort of what we have to do to make it sustainable. So as I said, that over 75 health assessment, it's a great time and opportunity for patients, and perhaps sort of looking at that bigger picture, those patients, yeah, will discuss it with others. They will discuss it with their family, you know, who are younger, and maybe they might see that as a good idea. So it's certainly not just for elderly or palliative patients, but when you're looking at that general practice setting and got to build it into existing Medicare benefit schedule items, that's the way that we found it works extremely well. And so, as I said before, there were the two projects that were running in, you know, a true collaborative style between two health agencies in Geelong, Barwon Health and the Medicare Local, working together to actually support general practice and the wider community. That's just a photo of one of our workshops. So all these people are GPs, practice nurse, or the outreach facilitators, and they this GP here was showing, he was one of the lead ones that was going around doing his presentation. They developed a consent form to discuss with patients. They had their patients knew a lot about it. It was discussed in team meetings and settings, and so he was then telling the others what he did in his practice. And as I said, you can't just pick up what someone does and plonk it into your setting. It's not always going to work, but if you can take some bits from that and create the jigsaw yourself.
Just point out Frank and Tina at the top of that other table. Can you point them out?
Yes, I will. So this is Frank and his
wife,
they're a married
Tina.
Couple. Solo GP beside the funeral parlour.
and Tina, as you can see, is talking about it there because she was a great asset to Frank, and she actually talked to a lot of patients before they actually even got to see Frank, so as they were coming in through the clinic. Yeah, they're amazing.
They are. And we actually thought that it may not, we thought that his practice might struggle being solo GP, no practice nurse support. I actually thought in my initial thoughts that it would be, they wouldn't necessarily perform well, so I'm wrong. So I guess the benefits of that, these projects and the benefits of advanced care planning within the general practice setting is with GP engagement in the advanced care planning process, empowers patients to make decisions about future health care in familiar and trusting environments. As I said before, they've already got a rapport with practice staff. So it's not just about the GP, it's about the whole team. There is that use of existing MBS item numbers that support advanced care planning activity as the business model. Our thought, and certainly I guess for this audience, is that through these projects and through this increased number of people within the community that have got advanced care plans in place, that potentially more people will be going into aged care facilities with a plan in place, and certainly with a discussion. And if they've got that plan in place, then it can get reviewed, and obviously it would need to be reviewed then because, you know, circumstance change to make them, to have the need to go into an aged care facility. So we're, you know, anticipating there's that potential that patients will already be going into aged care facilities with a plan in place. And of course it builds stronger, healthier communities, and when you've got proactive and engaged in self-care, improves the outcomes. So I won't go through all this necessarily, but this is sort of just a chart showing that the use of MBS item numbers for advanced care planning, the different claimable services, utilising the health assessment items, which is the 75 plus, or Aboriginal and Torres Strait Islander health assessments, comprehensive medical assessments in aged care facilities, case conferencing options within aged care facilities, chronic disease management, a GP management plan and review of that plan, incorporating advanced care planning discussion into that original plan, gives when patients are coming back for reviews. There's of course long consults at the aged care facility and medication management reviews. So there's some item number areas where it assists with just having advanced care planning discussions. That's you. That's me. So I guess the other thing, like this all worked for us because we had resources, external resources with funding through the Primary Care Collaboratives, which is the Department of Health, Victoria, and Department of Health and Ageing, federal. There was some funding opportunities through those departments, but also then through Barwon Health, through the fact that the CEO at Barwon Health, who I do believe was a GP in his day, very passionate about advanced care planning, saw the value in this and provided funding Jill's way to support outreach facilitators. Barwon Medicare Local, supporting my role in getting this project happening as well, and then the in-kind resources of dedicated and passionate staff, as I said, like Rick Milner, who should be, you know, if he was on the payroll, it would be the hours that he's put in getting other people on board. He's more than happy to go out to other local practices and to have a discussion with them and sort of help them within their practice how it could work if they don't really sort of understand. So using that, as I said, dedicated and passionate staff is priceless.
In fact, the way we sort of engaged with the practices to start with was we booked them in. Rick and I went on a roadshow, spruiking the benefits and how this would all work and the process and so forth. And I'm sure if we didn't have that face-to-face, it wouldn't have been as successful as it turned out to be.
So in sort of summing up why it's working well in Geelong, and as I said before, you can't just sort of pick up something that we're doing and bring it over on the ferry and plonk it in with you guys and say it's all going to work, but we hope that you take some, what you take away is the fact that it's a piece-by-piece process, it's a collaborative process. Talk to each other, the other agencies, your community, engage with your Medicare local. Medicare locals, although they work the same way, do work in different ways, so there's different opportunities. They'll have different program officers running different programs, and that can depend on the need in the different Medicare local communities. So talking with your Medicare local is an important step. Why it's working well in Geelong, as you can see, we've got that solid relationship between the Medicare local and with Barwon Health. That's been existing for quite some time, so we're able to build on that. And not just with me in my role and Jill at Barwon Health, many of my colleagues at Medicare Local engaging with other people in other areas and departments at Barwon Health. The strong rapport between the Medicare Local and the Respecting Patient Choices program, which has been established over time through these common goals to make the situation better for the community. We're working sort of to strengthen our community. As I said before, that dedicated group of GPs, the palliative care special interest group, they're fabulous as my sounding board. The identified GP champion, Rick Milner. The fact that Medicare Local has a dedicated palliative care program, and so it supports a lot of these activities and runs that annual forum. And as we said before, that really in Geelong, fortunate I suppose, that we only have one local health service to engage with. So if any patients plonked in an ambulance at 3 AM, they're going to Barwon Health, they're going to Geelong Hospital. That's it. So that's all we have to deal with in essence. We do have private hospitals as well, but if they're in the initial stage in the middle of the night, that's where they're going to Barwon Health. And so if they've got the advanced care plan. It comes up on their electronic register as soon as the patient's admitted into the emergency department. There'll be a flag so they'll know where to go and look for it. So that does make it easier, and I talk to lots of other nurses in other areas, and I say, that's it, we've just got one hospital to deal with. They go, oh yeah, you know, that's a big difference, and I respect and understand that.
So just in closing, there's a list of helpful references. The Next Steps training videos was a project between Barwon Health, Deakin, Austin Health and the Victorian Quality Council. Provided some funding, and it's a terrific training resource. We use it in our workshops to demonstrate how good conversations occur, and also some great bad ones. So, and there's also a narrative around conversations as well, and it's a terrific resource. And there's a number of other websites there that are really very helpful.
So you can Google Victorian Quality Council Next Steps, and it will bring you to those training videos, and then you can click onto it. And they've been filmed by GPs in our area, and Rick Milner is one of them, and he's very, very good at doing the good conversation, the good advanced care plan discussion in his practice. He's also filmed doing the bad one, and he said it was really, really hard to try to do a really crappy job.
And it's very bad.
So it is worth having a look.
Yeah, but don't just look at the bad ones, please. Okay. Yeah, so that website is fantastic, actually. And just this is really how, I guess, you know, I felt when we first embarked on this early in 2012. You didn't know who to talk to, how many balls you were juggling up in the air, and I guess the biting of the pie, that really, as Marg was saying, just take one bite at a time and take one day at a time, and is the way to go. But I have to say, with the collaborative project that occurred, when did that start? About April, May.
Yeah,
when that came on, I really felt like, oh my gosh, it's not just me, there's this other support that's there as well now, and it was fantastic, and it worked terribly well for all of us, I think. So don't feel like this, talk to others.
We thought we'd leave a bit of question time if you've got any questions in particular. Yes?
If you hadn't had the CEO support and the resource funding for the outreach facilitators, could this project have worked? With just GPs doing it in their practice?
It would have been very difficult. I would say we would have done something similar, but perhaps not with an outreach service, which would have meant that we would have to have them all coming back to us, because we wouldn't have been able to afford to provide facilitators going out all the time.
So that, you mean that the patients that the GPs refer would have had to come into the respective patient choices consultation?
Yeah, which is what happens with those that are engaged in the process.
And then you would have been potentially flooded with...
Yeah, but also it makes the process so much longer, because you've got to send them back to their GPs for another conversation and having the documents witnessed. So by doing it within the practice, it actually shortened everything up. So it's really a good bang for your bucks, really, because you can do more with that time. If we hadn't been successful in being able to move forward with the model, we actually had between us in our office decided that we probably would go out to practices and still do it, because it does work so well in the practice.
When you say we, who are you referring to?
Me and my colleague Debbie, so two of us. Because we can do more in a practice than we would ever do in our office, yeah.
And as putting my practice nurse hat on, speaking, that it probably wouldn't work, because we have had a lot of practice nurses that have gone and done the training, so training to be able to start and complete the advanced care plan process. But when it's not your bread and butter work in general practice, there are, you know, legal paperwork to sort out and that sort of thing. Nurses would take that step back and be uncertain, because they're just doing it sort of ad hoc and trying to build it into existing item numbers and an existing workload within the general practice.
So having a dedicated role made the difference?
Yes, yes, yeah. A lot of the nurses that have done the training said the training was great because it gave them the confidence just in their routine work to be having conversations with patients and not be shying away, and being able to discuss it and perhaps initiate it throughout a conversation. But so that training was valuable for them in that respect, but it didn't lead on to completing advanced care plans. Yeah.
And I guess I should say a function of our program is that we're control freaks, and all completed documents come back to us for auditing. So if they're not right, we can send them back and say, look, you know, this needs further clarification, so they're not too ambiguous, or if they're not witnessed correctly or dated, because, you know, they're as good as they are valid if they're done properly. So it's about a quality process too. So by us still being engaged with the practices, we're making sure that happens. Whereas if we had isolated people just doing advanced care planning willy-nilly, it may not be done as well, or it may not be distributed appropriately, those sorts of things. Yeah.
I think you made the comment to me over on the ferry that sometimes completing that paperwork not very well at all is actually worse than not doing it at all.
Yeah, it can confuse matters. Yeah.
Make it worse. Yeah.
I've got a question. Are you doing any targeting of the people who are you're targeting the advanced care plans? Is it, you know, the most vulnerable people, or the frail people? How are you targeting?
Well, certainly the over 75 health assessment puts you in that age bracket. Anyone with chronic or life-limiting illnesses, and then really anyone else out of who wants to do it, because it should be for anyone who wants to, but definitely that cohort is at the top. Yeah.
And do you see, is there a big group of people that you feel that you're missing?
I don't think we're missing them, but I think in general practice it's being missed is those with a diagnosis of dementia. We don't have a big uptake, so we're doing a bit of work with our memory clinics and our local Alzheimer's Australia group, and we're going to focus on dementia in general practice this year, because I don't think it's seen as an illness that's possibly life-limiting for that person. It's not recognised well by our health professionals as that.
And so perhaps in that health professional setting, they're thinking more about the over 75 or those with chronic disease.
And the COPDs and the CHFs.
Because that's easier, it's an easier flag in their mind in that busy day trying to remember everything. And as Jill said, that's sort of the dementia cohort.
And really perfect group to engage early on in advanced care planning, because their capacity is going to reduce. Yeah. We just did a little snapshot of just our Barwon Health residential aged care, and very low incidence of advanced care planning in our dementia-specific areas. So that's going to be a focus for us for 2012. 13, sorry.
Have we got any other questions?
How do you share advanced care plan with other health professionals? Like a patient in Geelong gets involved in car accident, gets flown to Alfred Hospital.
Yeah.
How? And he's in coma. How do you deal with that situation?
An incident like that actually happened where we had a couple do their advanced care plans. He actually had quite severe heart failure, had been referred to us through the heart program, and he and his wife both did their advanced care plan, appointing each other as medical power of attorney, but also there's a son each as alternate agent, and they had a horrific car accident. He actually died at the scene, and she was flown to Melbourne. It occurred on the Peninsula, and so because she had appointed an alternate agent, he was immediately able to step up and make decisions on her behalf, and he had a copy of the advanced care plan. So that's how that worked for that couple. In our local area, we make sure that the family medical power of attorney have a copy, the GP has a copy, Barwon Health has a copy. If they've got a record at the private hospitals, they get a copy. So wherever there is a medical record for that person, we try and put a copy in, including their specialists, if they're seeing specialists privately. Yeah.
Any other questions? Okay, thank you very much. That was fantastic.